I would like to welcome you to this overview of the 2010 Upper Peninsula Community Health Needs Assessment. I am Robert Van Howe, the Provisional Medical Director of the Western Upper Peninsula Health Department and the Dickinson Iron District Health Department. I will begin this overview by listing the objectives of this project. First, we wanted to gather accurate, actionable local information. Second, we wanted to advance knowledge regarding our local health status, our future health needs, and to identify health-related priorities. The Upper Peninsula Community Health Needs Assessment grew out of a requirement embedded in the 2010 Affordable Care Act, otherwise known as Obamacare, in which non-for-profit hospitals were required to perform a community health needs assessment every 3 years. The first Community Health Needs Assessment was published in 2012 and included the counties of the Western UP Health Department. In 2015, it was expanded to include Iron County, and in 2018, it was expanded to include the entire Upper Peninsula. At that time, questions regarding health priorities were added to the survey. So why are we doing this? While we want to identify problems in our areas, we also want to identify which things are public health priorities to help inform our action plans, our policies, and also to provide a baseline so we can see whether the policies and plans that we've implemented in the past have been successful. The assessment also includes a snapshot of the community at this point in time. The demographics, health needs, and health priorities of the Upper Peninsula are not aligned with those of the Lower Peninsula, so state-level assessments do not apply to the Upper Peninsula. Unfortunately, we have very limited data at the local level. National surveys only question a handful of people in a rural county, and even when the state of Michigan collects data at the county level, it pools 3 to 5 years worth of data together in order to give any actionable information. The Upper Peninsula Community Health Needs Assessment was a collaborative effort of 48 agencies, including all 6 local health departments, the hospitals and clinics in the region, behavioral health agencies, health foundations, and the Michigan Health Endowment Fund. Here is a list of our partners. I'm not going to read through all of them, but you can pause this presentation if you want to take a closer look. The current iteration of the Upper Peninsula Community Health Needs Assessment is built on the work of Ray Sharp and Dr. Terry Frankovich, who have both moved on to other endeavors. This assessment continues to look at our demographics and vaccination rates, communicable diseases, mental health, adolescent health, maternal and child health, chronic diseases and mortality, our local survey of health needs and health priorities, as well as the county dashboards. We've brought back a look at crime and safety data that was in previous editions, but not in the 2018 edition. In this new edition, we have made changes to simplify navigation through the document. So we included a detailed table of contents, a list of all tables and figures. We added discussions of the local impact of the COVID-19 pandemic, the health effects of e-cigarettes, marijuana legalizations, substance use disorder, and the uptick, pardon the pun, of anaplasmosis cases. Given the trove of data collected in our survey, we've included an in-depth analysis of the impact of demographics and health risk factors on the diseases seen in our population. The assessment relies on 2 sources of data. The survey we sent out to the Upper Peninsula residents is our primary source. The questions in the survey were based on the Centers for Disease Control and Prevention's Behavioral Risk Factor Survey. It contains 76 items and a survey of 16 health priorities. Secondary source information came from published databases that are managed and aggregated by other people. We tried to find the most recent data collected from respected sources. Data adjusted for demographic factors were preferred. When available, we looked for data at the national level, the state level, the regional level, and the county level, so we can make comparisons between each level. Vital statistics extracted from birth certificates and death certificates included the entire population and provided a reliable data set. The U.S. Census has robust data on age distribution, household income, educational level, and housing statistics. We collected data on the rates of births, deaths, infectious diseases, behavioral health issues, substance abuse, traffic accidents, violent crimes, and vaccinations. The list of sources we used is fairly long. So once again, you can pause this presentation if you need to take a closer look. The primary source is the 12-page survey we distributed that asked for demographic information, included multiple choice questions, and offered the opportunity to rank the 16 health priorities. Because Keweenaw County only has around 2,000 residents, we included the Keweenaw County as part of Houghton County. Once collected, the data was weighted according to a standard population for age, gender, income level, education level, and county population based on the 2020 Census Bureau data. So, why did we do this? I'll give you an example. The average age in Houghton and Marquette counties is lower than the rest of the Upper Peninsula. So when we discover that the rate of hypertension is lower in these counties, is it because hypertension is less of a problem in these counties, or because their population is not old enough to become hypertensive? When we weight the data by age, it allows us to make a direct comparison between counties that takes the impact of age out of the discussion. Another example, the same number of surveys was sent to both Ontonagon and Marquette counties, but Ontonagon returned far more surveys than Marquette, even though the population of Marquette is much greater. In determining what is happening at the regional level, if each survey is given equal weight, a response from Ontonagon would have a larger impact. To avoid this problem, the responses for each survey are weighted based on the county's population and how many surveys were returned in each county, thus allowing the results of the surveys for each county to be proportional to the population of the county. 1,700 surveys were mailed to each county, and we expected that 1,500 would be delivered. Surveys could be completed online, and we saw an increase in online responses. 16.9% of surveys were completed this time around, as opposed to a completion rate of 23% in 2017. This represents a 26% drop in the response rate. This drop may reflect a shift in attitude toward public health departments during the COVID pandemic. It also may be that our population has been surveyed ad nauseum. Nearly every call to customer services is met with an offer to stay on the line for a brief survey. Nearly every online purchase is followed by an email asking to complete a survey. Even fast food restaurants are offering free hamburgers for completing a survey. People are pretty sick of being surveyed. This graph shows the survey response rates in the different counties for each of the surveys starting in 2012 and ending in 2021. As you can see, there's been a steady decline, but similar declines across the counties. So who completed the survey? The average age is 65 in the most recent survey and 64 in 2017. It was primarily females who filled out the survey. Those with a 4-year degree or higher were more likely to complete the survey in 2010 than in 2017. Likewise, those with a household income of about $50,000 per year were more likely to complete a survey in 2021 than in 2017. So, compared to 2017, those who responded in 2021 were significantly older, better educated, and earned more money. Each of these differences was statistically significant. Mark Twain famously said there are 3 types of lies: lies, damn lies, and statistics. So before we look at the numbers, it's important to point out that changes reported are relative changes, not absolute changes. For example, if you go from 4% to 5%, that's a 25% relative increase, but it's only a 1% absolute increase. So what changed in the survey responses? One area was a marked change in substance use. Those who admitted marijuana use in the past month nearly tripled. This might be attributed to the fact that marijuana was legalized since the last survey. With legalization, people are either more willing to admit they use marijuana, or there are more people using marijuana compared to 4 years ago. Using over-the-counter medications to get high doubled, while the use of prescription medications to get high increased by 71%. Likewise, snorting and injecting drugs increased by 56%, and binge drinking increased by 43%. Vaping or using electronic cigarettes increased by 40%. An abrupt change took place in the field of mental health. Those reporting poor or fair mental health in the past 14 days increased by 34%. Depression increased by 22%. Calling a crisis line in the past 12 months also increased by 64%. Taking medication for mood disorder increased 25%. Receiving counseling increased 46%. Encountering a lack of mental health services increased by 79%. Of note, in the priority survey, those who listed the lack of mental health services as a high priority increased from 37.5% to 47.5%, the largest increase of any of the priorities. A disturbing finding was the decrease in preventative services. We saw mammograms go down 11%. Pap smears decreased by 39%. Prostate screening increased by 16%. PSA testing for prostate cancer decreased by 33%, and stool occult blood testing used to screen for colorectal cancer decreased by 12%. These decreases may reflect the limitations in access to a primary care clinician for regular checkups during COVID. Colonoscopy bucked this trend, as it was a procedure that could easily be scheduled and took advantage of the open surgery schedules while COVID was going on. Physical activity decreased during this time span. Those reporting no physical activity or exercise during leisure time increased by 16%. I've always taken this question with a grain of salt because I'm sure that a person who is a mail carrier who walks all day doesn't really feel like doing physical exercise in their leisure time. Another measure based on the time spent in vigorous and moderate aerobic exercise also decreased by 13%. COVID restrictions may have kept these people at home. For some reason, those reported always wearing seatbelts increased by 29%. Fear of COVID and familiarity with the impact of vaccine-preventable diseases may have prompted the influenza vaccine rate to increase in those 65 years of age and older. These people did not want to get influenza on top of COVID. Dental care has been on a rocky road in the past 4 years. Those without any dental care in the past 12 months increased by 16%. Those without dental insurance doubled. The lack of access to dental care increased by 67%. Access to dental care as the highest health priority increased slightly, while most priorities decreased sharply. This change in priority was seen most acutely in Alger, Chippewa, Gogebic, Houghton, Keweenaw, and Luce counties. Dentists have been retiring across the region. Unfortunately, these professionals have not been replaced. The same 16 health priorities that were listed in the 2017 survey were included in the 2021 survey. Of interest are those who answered very important should be a priority, as opposed to fairly important, fairly unimportant, or not an issue. Of the 16 priorities, 12 of them decreased. The priority ranking varied by county. This graph shows the percentage of those who found a health priority to be very important. The priorities are listed on the left, and the response rates for 2017 are in the red bars, while the response rate for 2021 are in the blue bars. As you can see, mental health had the only big increase. Healthcare costs remained the number one priority, but dropped from 71% to 58.4%. The issue of unemployment, wages, and the economy moved from the number 4 to the number 2 spot, but still saw an overall drop in those who ranked it as very important. Drug use dropped from number 2 to number 3. The big up-and-comer was the lack of mental health care services, as it moves from number 6 slot to the number 4 slot. The 10% absolute increase in those who thought it a highest priority was not seen in any other health priority. A lack of health insurance moved from number 3 to number 5. Since the passage of the Affordable Care Act in 2010, we have seen with each survey a further decrease in those without health insurance. Let's look at our secondary data to see how we've changed over time. Our population has been fairly stable in the counties in the Upper Peninsula, but all of them are older than the average for the Lower Peninsula. Houghton and Marquette have younger populations because of the college students. The census counts where you were living at the time. So if you're a college student, it's where you're going to college. If you're incarcerated, it's the county in which the prison is located. In a new twist, we looked at asset-limited, income-constrained employed, also known as ALICE. This uses the household survival budget, which is based on where you live and how many people are living in your household. Studies have compared this to the poverty threshold and found it provides more useful information. A lot of people are above the poverty line but below the household survival budget. These people were not able to tread water. Of note, people over 65 were less likely to be below the poverty threshold because of Social Security and pension payments, but more likely to be in financial trouble than those who are younger. This graph shows our population change as a percentage beginning in 2010. The solid black line is the state of Michigan, and the dashed black line is the Upper Peninsula. The orange line is Cogebanque County, with a sudden drop between 2018 and 2019 that was the result of the closure of their prison. There has been a lot of speculation regarding a potential increase in our population as demand increases to move here to escape climate change. I fear the 2020 census may be inaccurate because of the COVID pandemic. This graph provides the percentage of population by age group in each county. The youngest age group is at the bottom, while the oldest age group is at the top. You can see that Houghton and Marquette County have the smallest percentage of those 75 years and older. A disturbing and persistent finding is that smoking during pregnancy is extremely high in the Upper Peninsula. While the rate is about 14% in Michigan as a whole, our rate is 25%. Several counties had rates above the 25% mark, with the rate as high as 40% in Keweenaw County. Neonatal abstinence syndrome impacts newborns that are withdrawing from substances they were exposed to before birth. As you can see from the numbers on this slide, the rates in the Upper Peninsula are almost 4 times higher than the rates for Michigan. The rate is higher in whites and Native Americans in both regions. To give some historical perspective, the rate was 13.1395 in 2010, then peaked in 2010, and the rate has come down to our most recent data from 2019. Evaluation of local adolescent health was hampered by the lack of local data. Communities that care surveys were not consistently undertaken because of loss of funding as well as the COVID-19 pandemic. Instead, we are reporting state-level data. We are seeing some decreases in cigarette smoking, but that's been offset by increases in e-cigarette use, vaping, and marijuana use. There are high rates of depression, and Michigan adolescents are less likely to get a full night's sleep than adolescents in other states. Vaccination rates were increasing from 2013 through the first quarter of 2020 when COVID hit. Since we were unable to have face-to-face encounters with healthcare professionals, we weren't giving shots. Consequently, there was a precipitous drop in the number of vaccinations administered. Since then, we have not come back to the pre-pandemic vaccination rates, and we haven't had the compensatory rebound we were expecting to make up for the vaccinations not given during the pandemic. This may reflect an increase in those who have come to question the role of public health during the COVID-19 pandemic. As far as contagious diseases are concerned, COVID-19 dominated the news, and there's a large section in the report about the local health impact of COVID-19. We have also seen an increase in tick-borne illnesses like Lyme disease and anaplasmosis. With warming temperatures, we're starting to see some eastern equine encephalitis in our region. This is a picture of our favorite tick, the deer tick, who is responsible for spreading both Lyme disease and anaplasmosis. This map shows the number of cases of anaplasmosis in Michigan. Like we saw with Lyme disease, anaplasmosis is coming to us from Wisconsin and spreading north and east. This map shows where we see eastern equine encephalitis. The gray area shows where we have seen animal cases, and the red striped area is where we had a human case. The report also looks at a variety of chronic illnesses and our mortality rates. The diseases of interest include the usual suspects of cardiovascular disease, cancer, COPD, diabetes, Alzheimer's, chronic kidney disease, hypertension, and obesity. While the rates haven't changed much, we did have the opportunity to use the data from our surveys to see what impact our local demographic factors had on these illnesses and how these illnesses interact with each other. This 2020 graph from the CDC shows the number of deaths unrelated to COVID in dark blue and the number of COVID-related deaths in light blue. As you can see, the additional deaths in 2020 can be attributed to COVID-19. Substance use also changed with marijuana becoming legalized. Dispensaries are quickly popping up everywhere to the point that we could not keep track of them. The opiate crisis is continuing, and we have implemented a needle exchange program through the health departments across the region. This graph depicts the number of drug and opioid-involved deaths in Michigan in the blue bars. The yellow line represents deaths involving synthetic opioids such as fentanyl. Deaths related to heroin are represented by the orange line. As opioids have been prescribed less frequently, deaths from these substances have been replaced by heroin and other synthetic opioids. This table may be a little difficult to read, but it gives the numbers from the different health departments regarding their needle exchange programs. It includes the number of people served, how many syringes were distributed, how many were collected. The aim is to collect as many syringes as we can to limit the number of dirty needles out there. To treat accidental overdoses and prevent death, naloxone kits are also distributed. We also give out test strips that can be used to test the product that people are using for the presence of synthetic opioids, which can be very potent. We keep track of how many people we refer for treatment and the number of overdose reversals. Unfortunately, just as some of these programs were launched, the COVID-19 pandemic arrived. The COVID-19 pandemic has had a huge impact. It exposed limitations in our capacity to provide health care. It exposed the impact of the limited funding provided for public health. We're finally getting funding that we didn't get before, but public health funding has a history of cycling between panic and neglect. The pandemic highlighted the negative impact of politics on population health and exposed the weaknesses of having a mixed model public health system. In our mixed model, local health departments must rely to some degree on the state, who often were not a reliable partner. In response to the pandemic, we had to decrease access to preventative care services such as vaccination and health screening procedures. We saw decreased levels of physical activity. Finally, mental health and substance use issues are on the rise. It is unclear if this is from increased awareness and increased public acceptance of these issues or actual increases in illness. We have an aging population with a plethora of chronic illnesses. While Social Security keeps the elderly above the poverty line, it's not sufficient for them to meet their basic economic needs. We continue to have pressures to address demands for dementia care, assisted living, and nursing care. To meet these demands, we need a workforce to provide services for the elderly. A number of preventive opportunities persist. We need to vaccinate for COVID. We need to address smoking rates, drinking rates, obesity rates, dietary habits, and physical activity. Many of our health issues begin as social issues, which are often referred to as social determinants of health. We found that in nearly all the illnesses that we looked at, those with lower income levels had a higher rate of disease, and oftentimes lower levels of education was associated with higher disease burden. One of the things that we can learn from this enterprise is that repeated looks at secondary data can alert us to trends that impact our region and our counties. By using the same survey tool, we can make a direct comparison to where we were 4 years ago. We found that community input is essential in formulating effective, appropriate policies and action plans. Information from this assessment can be used by people, groups, agencies, and local governments across the region and also within counties to help them support applications for grant funding. Going forward, we will be reaching out to our communities to help us with the next iteration of this process. So what can you do? Let people know how important accurate information is for health planning and encourage participation either in focus groups or surveys. You can contact us if there are specific questions that our large database might be able to answer but were not addressed in our report. Become involved in actions to improve the health of our communities. A full copy of the assessment and 2-page dashboards for each of the counties are available at www.wuphd.org. I want to thank you very much for watching this presentation.